Question 101, we have a 65-year-old male who has advanced lung cancer and has had chest wall pain for the past few days. He self-medicates with paracetamol, still has pain. Which of the following is the most appropriate control agent to prescribe? I'm going to go for codeine, and that's using the WHO stepwise ladder for relieving pain. Order would be non-opioids, which could be aspirin as a non-steroidal, other non-steroidals and paracetamol. Next step is mild opioids like codeine, and third step is strong opioids like morphine. When you're at one step of the ladder, what you do is you make sure they're receiving this medication regularly, and that means every 3 to 6 hours, as opposed to having it just when they request it or demand, and then only when they've been on the regular medication that you go to the next step of the ladder. Right, question 102, you've got a 48-year-old male, 1 year down the line from a lung transplant, consults you that he's got a productive cough and fever. He's taking an immunosuppressant agent, tacrolimus. Which of the following antibiotics should not be prescribed in view of his coexisting medication? So basically, we need to root out the medication that could affect how it is metabolized, and that would be clarithromycin. So tacrolimus affects the cytochrome P40 system, and lots of drugs sort of interfere with how well it works. For instance, you've got calcium channel blockers, antifungal drugs, and macrolide antibiotics, clarithromycin being one of them. You've got other medications such as anticonvulsants, rifampicin, that can decrease tacrolimus concentrations, and you've got other substances sort of like grape juice, fruit and herbal substances such as St. James wort, which should be avoided during taking tacrolimus because they can affect the levels. Right, next question is question 103. You've got a 55-year-old diabetic male with a history of stable angina. He presents with precordial chest pain at rest for the last half hour. You suspect he has unstable angina. His ECG shows ST depression and his troponin is elevated. You've given the initial therapy of oxygen, morphine, aspirin, and nitrates. Which of the following should we also consider administering? So we've got somebody who's got an NSTEMI. We've given our initial mono treatment, which is the morphine, the oxygen, the aspirin, and the nitrates. Next step would be to administer low molecular weight heparin, because this gentleman has an acute coronary syndrome. Acute coronary syndrome comprises of non-STEMI or non-ST elevation MIs, as well as unstable angina. It's very different from STEMI, which means we actually have ST elevation on our ECG. How would we know that somebody is suffering from acute coronary syndrome? It's any change basically in their chest pain. As we had in this case, he had prolonged episode of angina which occurred at rest that wasn't relieved by his GTN spray. Other warning signs are if your previous angina is getting worse, it's becoming more frequent, it's taking longer, and you're getting less responsive to your GTN spray. ECG can show a number of changes. Most importantly, we don't have ST elevation, or if we do, it's very transient and it's spontaneously resolved after taking nitroglycerin. You can have ST depression, as in this case, T wave inversion. You can have Q waves, left bundle branch block, or anything basically that isn't specific. So our initial management is history examination, doing an ECG, asking our lovely nurses to take some observations for us. Most important blood test is high sensitivity troponin, and we do our Gray score. Initial management, as we all know, is our MONA, which is our morphine, our oxygen, our nitrates, our aspirin. In addition, we can also give clopidogrel if they have allergies to aspirin, and that would be a loading dose of 300, just like aspirin, followed by 700 milligrams daily, and that would be for 12 months. Low molecular heparin, we usually go for enoxaparin, which is 1 milligram per kg, 12 hourly, and that's usually given 2 to 8 days, depending on the clinical risk of developing continuing ischemia. And then nitrates, we obviously have a choice of oral and IV nitrates. And pain, we could give morphine or diamorphine along with an antiemetic. Question 104, we've got a 65-year-old female presents with recent onset central crushing chest pain, which is radiating to her arm, which is unrelieved by GTN spray. You suspect she's having an MI. You start her on oxygen and morphine. Which other drug should you consider starting at this stage? It's obviously going to be our good old aspirin, part of our MONA. If you've got a contraindication to aspirin, then you go to clopidogrel, which is also a loading dose of 300 to 600 milligrams. Next step is question 105. We've got a 50-year-old obese male diagnosed with type 2 diabetes a year ago, and it's his annual diabetic follow-up. He has been moderately compliant with his dietary precautions and takes metformin and glipizide. His other medications are propranolol, nifedipine for hypertension, naproxen, and he started the naproxen 2 weeks ago for severe knee pain due to osteoarthritis. On examination, his blood pressure is 140/92. He's got a fourth heart sound. Remaining part of his physical examination is normal. Routine U&E reveals a urea, which is raised of 10, creatinine, which is also quite raised of 160. And then this is different to his baseline test a year ago. Which of his medications is likely responsible for the increase of his urine and creatinine? Also, pretty much a no-brainer. It's naproxen, which is a non-steroidal that is used in first-line management of osteoarthritis. Right. So it's not glipizide, because glipizide might cause hyperglycemia, but it doesn't cause renal toxicity. It's not metformin, because metformin usually causes lactic acidosis in someone who already has underlying renal damage. It's not nifedipine or propranolol, because they have no effect on the kidneys whatsoever. It is our good old non-steroidal, which can cause pre-renal damage. Other medications which you have that can cause pre-renal damage are ACE inhibitors, particularly if you have a renal artery stenosis. There are other agents which can destroy different parts of the kidney. So you can have intrarenal damage. That's with penicillamine, gold, things like claptopril, phenytoin, and lots of antibiotics, such as penicillins and sulfonamides. You get interstitial nephritis, and that damages the interstitium, which is between the tubules and the glomeruli, with agents such as non-steroidals, thiazide diuretics, furosemide, and rifampicin. You can get acute tubular necrosis, which usually happens secondary to hypovolemia or hypotension. It can be caused by agents such as aminoglycosides, amphotericin, and cyclosporin. You get post-renal damage, which is caused by agents such as methotrexate, or you can get renal damage as a consequence of having urinary obstruction secondary to urinary retention by agents such as anticholinergics and tricyclic antidepressants. You've got other nephrotoxic agents such as lithium, which causes nephrogenic diabetes insipidus. We've got our next question, which is question 106. A 24-year-old female who's 10 weeks pregnant would like some advice concerning an analgesic for a headache. Which of the following is the safest to use during pregnancy? We're going to go straight for our good old sturdy paracetamol. And the reason why we've gone for paracetamol is because if we went for non-steroidals, we can't really do that because non-steroidals have pretty big risks in both the first and third trimester. First trimester, you're at huge risk of miscarriages from it. Third trimester, you're at risk of premature ductus arteriosus. Aspirin isn't a good choice because aspirin has been associated with intrauterine growth retardation, and opioids aren't a good choice as well because they've been associated with heart defects, spina bifida, and if they're given late during the third trimester, they can cause respiratory depression and withdrawal symptoms. Next question is question 107. You would like to prescribe alendronic acid for a 70-year-old female who's got osteoporosis. What's the best way to counsel her regarding taking her medication? I always remember it as the 30 rule. You have to have an empty stomach. You have to have it 30 minutes before breakfast, and you need to remain upright for 30 minutes. and that's because it's associated with causing severe esophageal reactions like esophagitis and ulcers and strictures and erosions. Question 108, you've started a 45-year-old gentleman on metformin. However, he's failed to control his hyperglycemia. Which of the following agents would you consider adding in now? So our usual chain of action when we've got somebody with type 2 diabetes is number one, we start with lifestyle changes, such as eating healthily, exercising, that sort of stuff. Next step, if that fails to avail, is we go on to giving metformin. Third step is we give sulfonylureas such as glycoside, and that's provided that we're not worried about this patient having hypoglycemic episodes and we're not worried about weight gain. Question 109, we've got a 70-year-old female who complains of constant shooting pains along the side of her chest following a bout of shingles. Which of the following is the most appropriate pain control agent? And this is also a post-herpetic neuralgia, so we're going to go straight for our amitriptyline. If that doesn't do the trick, then we can go on to gabapentin, and also another means of controlling the pain could be topical preparations such as caspasacin, 0.075%. Lidocaine has also been known to be helpful in some patients. 110, we've got a terminally ill patient who's receiving 300 milligrams of slow-release morphine. Despite these doses, he continues to experience breakthrough pain, so you want to give him a rescue dose of pain relief. How much oral morphine do you write him up for? So breakthrough pain is usually 1/6 to 1/10 the amount of the pain relief that the patient is taking throughout the whole day. So a tenth of 300 milligrams would be 30 milligrams, and 1/6 would be 50. So we're going to go for 30 milligrams. Usually breakthrough pain is given at an interval of every 2 to 4 hours, or if we know they're going to do something that's going to cause them pain, we just give it a breakthrough dose sort of 30 minutes before that, so we're sure that it's worked. If the patient is requiring regular breakthrough pain doses, then we need to review the total amount of analgesic that the patient is receiving. Question 111, we've got a 10-year-old girl who's complaining of fatigue, malaise, fever, joint pains in her big joints, which are her hips, her knees, her shoulders, and her elbows, and that's been going on for 3 months. She's got a salmon pink rash that's affecting the trunk and extremities. Which of the following is the most likely diagnosis? So we've got a young girl who's got 4 big joints involved, and she's got a systemic symptom of rash. So it's going to be chronic juvenile arthritis. Okay, so it needs to be in a patient that is younger than 16. It needs to have lasted more than 3 months. It's got 3 different types. It can be polyarticular, polyarticular, depending on the number of joints, 4 being the cutoff number. It also has a systemic onset subtype, which is known as Still's disease. This has a triad of fever, rash, and arthritis, which is that typical salmon pink rash that we had in our question. These poor children usually always have an elevated ESR. When we do a full blood count, they can experience sort of pancytopenia, anemia, lymphopenia, thrombocytopenia. They have a positive anti-nuclear antibody in 25% of cases. And some children also have rheumatoid factor. Mainstay of treatment is physiotherapy, occupational therapy, and can also go for disease-modifying drugs as used in rheumatoid arthritis in adults. Disease-modifying drugs, we usually go for methotrexate. We can go for corticosteroid, but that's reserved for the children that have life-threatening complications or eye involvement. Etanercept is used when you have at least 5 joints involved and they've not responded to methotrexate. It's some pretty nasty stuff, and it can cause osteoporosis, growth retardation, and uveitis. Question 112, we've got a 10-year-old asthmatic who attends his GP practice for an annual asthma review. He's only on a salbutamol inhaler. However, he admits to nocturnal symptoms most of the day, most nights of the week, What is the most appropriate medication change? And that would be going through our stepwise sort of steps of changing or reviewing asthma. So the next step would be to introduce budesonide, which is an inhaled corticosteroid. Oh, yep. So first step is, so when would we step up? We'd step up if you have symptoms at least 3 days of the week, or if you have even just one night episode of an exacerbation. So we've got 5 steps. First step is where we just use our salbutamol. Step 2 is when we add in our inhaled steroids, and that would be at a low dose of 200 to 400 milligrams. Step 3 is when we add our LABs in, like 𝕊𝕆ₛ𝕀𝔸𝕃. If that doesn't control it and they are responding to some extent to the 𝕊𝕆ₛ or the other LABA that we're using, then we keep that and we increase our steroids even more to 400 if they're not already on 400. If they're not responding to our LABA at all, then we just increase our steroids. Our 4th step would be to go to the maximum dose of steroids, and that would be 800 micrograms. And our 5th step is adding in oral steroids. Right, next question. We've got question 113. We've got a 25-year-old male presents with a rash on his cheeks, sparing his nasolabial folds. A week ago, he had upper respiratory tract infections, feeling unwell, sore throat, fever. On examination, you also note he's got a rash on his arms and his trunks. What is the most likely diagnosis? So this is our sort of pill here. We've got a rash that's sparing the nasolabial folds, so it's going to be 5th disease. 5th disease is also known as Erythema infectiosum. It's caused by human parvovirus B19. It's usually preceded by an upper respiratory tract infection. It's got an incubation period of 7 to 10 days, and then you get prodromal symptoms, which last 2 to 3 days, a week after exposure. And then you have a symptom-free period for a week to 10 days, and then you start to get the rashes. The first rash that you get is the slap cheek appearance, which characteristically has the nasolabial fold sparing and circumoral pallor, as you can see here in the image. The next phase, which is 1 to 4 days later, is when you get an erythematous macropapular rash on proximal extremities, such as the arms and the extensor surfaces, as well as the trunk. And this has a lace-like reticular pattern. And then you get frequent clearing and recurrence for months to weeks, and stimuli such as exercise can provoke it coming back. Sometimes if somebody who's immunocompromised develops 5th disease, then immunoglobulins have been found to be helpful. Question 114, we've got a 1-month-old girl who's seen in A&E with shortness of breath. Which of the following features is not indicative of respiratory difficulty in neonate? So the only one here that isn't indicative of a respiratory distress is abdominal breathing, which is normal in neonates. Our signs and symptoms of respiratory distress are a respiratory rate in neonates, is a respiratory rate of more than 60. If they've got any kind of recessions, if we can hear grunting, which is through the expiratory phase of breathing, and if we have flaring of the nasal ali, and if we have cyanosis. Question 115, we've got an 8-year-old boy with a history of atopy, is complaining of worsening shortness of breath. On examination, there is increased work of breathing, but he can just about manage sentences in one breath. There is an audible wheeze on auscultation. Which of the following is the most likely diagnosis? So, of course, this is shouting out asthma to us. And that's with the atopy, with the shortness of breath, with the increased work of breathing, with the audible wheeze. What is asthma? It's a chronic inflammatory disease characterized by hyperactive airways leading to reversible bronchoconstriction. Management would be oxygen. If our SATs drop below 92, we'd give our salbutamol or ipratropium bromide via a spacer or a nebulizer, and then we'd also add in steroids, which can be IV or oral.